fast-track treatment area into a virtual visit track within our emergency department. As many of you know, emergency departments, both in the United States as well as in many parts of Europe, are beholden to do a medical screening exam at the very least for every patient that enters the front door. We cannot turn people away or guide them to be seen in another area. And so we'll talk today about how we managed that historically, but also even more importantly about how we manage this in the context of the pandemic. And what we learned has also been helpful for us in managing the surge, the post-pandemic surge that we've all been dealing with internationally. And so just to begin, I wanted to give credit to this interdisciplinary team that included research and statistical analysis from my research laboratory, as well as the physician and nursing clinical operations team that runs our emergency department. Lastly, is additional health integration team within the technology and digital health solutions unit, our health IT unit within our hospital system. And it really took a lot of planning as well as coordination of all three of these groups to not only set up the research for this so we could understand how it was, and in many cases was not working, but even more importantly to deliver the intervention as part of our care process within our emergency department. And so our learning objectives are as here on the screen. We'll walk through each of these three steps. One of the things that many of you may know is that emergency departments really operate on the principle of the worst first. In addition to that, that really means, I should say, that the sickest patients should never wait. And as a result, there is sicker patients are generally prioritized for care spaces or beds that are limited supply during certain times of the day. And as a result of that, patients who have a lower acuity or who are there for a less severe illness will often wait because sicker patients will try to queue ahead of them. Now, what I have up here on the screen is a framework for emergency care called the input, throughput, output model. And what this illustrates is that in the emergency department, we have very little control over the input. Some of it is relatively predictable, relatively plannable, but not completely. Where we do have a little bit more control is in the throughput process, where, however, often our lower acuity patients will have a slower throughput as a result of us needing to address acute patients, things like traumas and critically ill patients who are needing critical care, as well as people who have cardiac arrest and other issues that need to be addressed more quickly. As a result of that, they often will traverse a little bit slower, and this is a generalized problem that about 20 years ago in innovation, really there was a movement to promote this idea of a fast track. And fast tracks were basically dedicated spaces for us to see lower acuity patients more quickly, knowing that there was a cohort of them in the mix of everybody arriving to the emergency department who could be pulled out of queue and seen quickly, moved along to create space for somebody else to come in. And so here on the screen, what I have are sort of examples of three different emergency departments as to what these care spaces look like. So for those of you who've been in a hospital, this is not your typical hospital care space. You'll notice that each of these spaces is equipped with what we call vertical space, where patients are generally well enough to sit upright in a care space. So this isn't the traditional hospital bed that you're probably accustomed to seeing in most areas of the emergency department or the hospital as well. There are also smaller spaces. You can actually fit more care spaces that are vertical than you can horizontal. Horizontal referring to patients who are in traditional beds. And so with that kind of space as the intervention that we had for these lower acuity patients, we had to change the model. And so the common theme for many of these presentations is that COVID-19 was quite the accelerant or catalyst for new care delivery options that engage digital health and meeting patients' needs, and this is no different. What we realized is that the pandemic created a couple of challenges that we like to think that we took and switched to make opportunities. And so specifically, it was really critical for these patients that we knew had a longer period of time in the emergency department, despite not needing as much from us, that longer period of time was not only unacceptable and unfavorable, it was dangerous. Those patients could either have COVID-19 being a part of what they're coming for, and now spread it to other patients who are in the emergency department, or walk in without COVID-19 and walk out with it because they've been in our physical care space longer than we'd like to. On top of this, the patients that we were seeing were fewer. We actually had a decrease in the volume of patients that we were seeing in most emergency departments throughout the world. However, they were much more sick. And on top of that, our workforce was significantly hit by COVID-19, which meant that we didn't have as many providers to see fewer, but albeit sicker patients. And so the idea of dedicating providers for a fast track on a low acuity area was a lot harder to justify. And so this was quite challenging. And what we really did is we took a step back and said, what we're seeing is that in-person contact is unsafe. In fact, our staffing resources are even more limited than they ever were before. And on top of that, patients were willing to be seen virtually because they did not want to come into the emergency department if they did not have to. And so in the setting of the national emergency in the United States, the government issued equivalency in reimbursement so that we could get paid for a virtual care visit the same as we would for an in-person care visit. And that really opened the floodgates for us to be able to innovate with this triad of patient willingness, the insurance financial scheme of being able to support it, and it being unsafe to have in-person care, so minimizing contact as much as possible. And so the last piece is that our providers were willing to learn virtual medical care delivery skills if it meant that they had less exposure to multiple patients coming through, all of whom were sick and often with respiratory complaints at that time. So we piggybacked off of an effort that happened in our health system to transform our primary care delivery system. Within a period of about 3 months, we transformed 75% of our primary care visits to virtual care encounters. This was a massive undertaking by the health system where we have a very wide catchment area, many patients getting care within our system, and didn't want there to be a lapse in care for a very complex patient population. So we took that same technology, however, we did it a little bit differently, as we often do in emergency medicine. We flipped the telemedicine implementation model. And so what you might be familiar with is more of this model here, which is the historical telemedicine model, where you have patients who are being seen in the spokes, if you will, of a network of hospitals. And there's a central hub where they have specialists that are not available at all of the satellite hospitals, so to speak, in this network. And what the telemedicine technology does is it allows for a care interaction between that specialist and a patient at a remote hospital, where they can provide guidance and advice on a treatment plan using the clinical interface, the technological interface. Now, what our health system did is we said, well, we're looking at patients who are all within our system. They get care in our system, our providers are within our system, but we're going to create a way for our providers to be able to see these patients through their phones and their computers while they're at home. Now, what we did in the emergency department was slightly different, where we actually had patients that were actively getting emergency care in our 2 facilities, being seen by one physician who was not even on campus for the early stages of this program. And so this was a bit novel in that it was a flipped model where the doctor was out and the patients were in. Now, this provider was able to order labs and tests, CT scans and MRIs, call consultations and admit patients to the hospital, despite not actually being in the hospital. And so just to tell you a little bit about our facilities and our hospitals, we are a level 1 trauma center based in Silicon Valley in California. We have separate adult and pediatric emergency departments. Our adult emergency department sees about 90,000 patients a year. Our pediatric emergency department will see about 30,000. And we have about 81 full-time faculty and a total of part-time and faculty of about 121 providers. And so with this group, we're able to really launch what was our design and implementation. What was interesting about this is that in each of these EDs, we carved out area within our waiting room to create virtual care spaces that were a lot like the fast track space, smaller. There's a place for the patient, but as you'll see on the right-hand side, there's also a telemedicine department in the back of the room that I'll give more detail on in just a moment. Our staffing was a nursing ratio of 4:1. We also had an ED tech who assisted not only with cycling patients into the care area and back out after their evaluation was completed, but also facilitated in the encounter with the physician the interaction between the physician, the patient, and the telemedicine part. On top of that, the physician workflow involves an interaction with the patient through the telemedicine part facilitated by the tech. And during COVID, this allowed us to be able to see patients again in 2 separate facilities, splitting the staffing of 1 physician with 2 lower acuity patient populations. So we were able to get them in and out of the emergency department for lower exposure, increased throughput, and you'll see in a moment, increased patient satisfaction. Now these telemedicine carts were equipped with otoscopes, stethoscopes. We're able to do a skin exam, cameras that could zoom in and zoom out. We also were able to take photos, include it in the medical records so that we could call consultations. And before the consultant would come down to the emergency department, would often have photos of the very thing we were asking them to come and see. Our techs acted as telepresenters where they were extensions of the physical exam for our providers. and were able to follow instructions and got quite good at them towards the end. However, we had a fail-safe where there was also the ability for the provider who was on an on-shift text messaging system to be able to reach out to any of the other doctors who were on staff in the emergency department to be able to come into the exam to complete the evaluation if there was any ambiguity. And that was included as a fail-safe of our continual iteration process. We didn't use often, but it was used in several cases to avoid the transition of patients out of telemedicine back into the mainstream care. And so with this, you'll see that we had our inclusion and exclusion criteria. At Stanford, as is the case with many emergency departments throughout the United States, we use the Emergency Severity Index. So this is a scoring system from 1 to 5, where 1 is actively dying, 5 is not very sick. And we score patients' acuity based on intake information from the triage nurses. After patients are registered in triage is where we start to screen patients for the telemedicine pathway. And so we included for screening patients with ESI 3, 4, or 5. So these are our lower acuity to mid acuity patients. You'll see our exclusion criteria on the right-hand side of the slide there. Notice here that most of the items that we've included are things that you need to do, use your hands for an evaluation or specialized equipment. Up there as well as abdominal pain, which was one that we thought was a great idea to include because we thought you need to put your hands on the patient. As we learned, our telepresenters got very good at following instructions to do a physical exam, and our physicians became very good at actually using that as a proxy. And so we actually included abdominal pain, and it basically was at the discretion of the provider that day to whether or not somebody was appropriate for this evaluation. Again, they're using the information from the triage nurse's short, brief summary why the patient is there. And in addition to this, age was included here, and by the end of the program, I'd say to the end of the program until currently, our youngest patient has been seen as 2 years old, and is 92. Really the idea that the chief complaint makes a difference. And so in terms of outcomes and metrics, to date we've had 6,000 patients who've been seen through a virtual visit care pathway. As you also see on the screen, this is a small proportion of all the patients that we see, but that small amount actually decompresses the emergency department of the low acuity patients. And on top of that, we have calculated that it actually allows us to see 65 more patients in main ED beds as a result of the program existence. So a lot of our return on investment calculations are less about how much money we make or are able to recover given the investment that we made, and a lot more to do with what else we're able to do with our care spaces because we have this program that's a faster turnover and a better use of resources for the patient's needs. We published our early findings in New England Journal Catalyst, and you'll see here on the slide that what we found early was that there are 7 months before we hit our resource investment break-even point, which was longer than we expected, but really accounted for the synergy between patients and us being able to understand the program and take full advantage of it. We had a shorter ED length of stay that was about 50% that of the main ED care evaluation for similar patients, and 100% of our physicians assessed the care quality as either excellent or very good. We looked at some interval metrics, as you mentioned, the input, throughput, output. So our input metric was the time to be seen, or the waiting room time. You can see the blue line as a virtual visit care pathway. The black line is the main ED evaluation. And on the other side, we have the median door to attending disposition. So this is really the active care time, which is, again, about 50% that of the main ED. And one of our safety metrics was 72-hour ED returns for the virtual visit track. And you can see here that the video visit track's return rates within 72 hours was lower than that of the main emergency department evaluation, making us much more comfortable with eventually scaling this project to see this program to see sicker patients, more patients, and include more care spaces. So of course, we are always concerned about our patients' experience when we innovate. And what we use in often the United States, but in our institution in particular, is what's called a Press-Ganey scoring system, where you have quintiles of scores, where the top box is really your top quintile, and we look at the percentage of patients who've given us top box scores. And in our case, we saw that about 80% of patients carried through this pathway gave us a top box score for their experience in our ED, and there's some other metrics you can see orbiting that central metric that have been favorable for us scaling again this program and continuing knowing that we're satisfying our patients. And so very briefly, what we learned in terms of lessons is that we really needed alignment at the early stages of the physician and the nurse's evaluation. The physicians often were comfortable seeing patients through virtual care, and the nurses were not. Other types of nurses would pull back patients back for care that they were comfortable with. The physician would meet them, and they would not, and we'd be sending the patient back out to the waiting room, which is not good for their care experience. In addition to that, having a dedicated telepresenter was critical. We realized that having the tech help to extend the physical exam during the evaluation and not just bring patients in and out was critical for the patient experience and also for the physician to get the most out of the interaction with the patient. And as a result, we changed our staffing so that there was a fully dedicated person. We're no longer splitting that tech with another area in the emergency department. Communication to inform patients on exactly what the care delivery experience would be like, had more patients consent to being seen through this process, as opposed to just saying telemedicine and hoping they thought that was the case. We realized that we were getting young patients pretty easily, but older patients were not understanding how that translated to be the same thing. By shifting our communication, we're able to bridge that gap and increase our acuity. And we had early metrics that we measured early and often, and we're able to use that as our continuous improvement process to optimize the program throughout. So with that, I'll maybe end with our key takeaways, and I'm happy to take any additional questions.
We open the floor for questions, gerne auf Deutsch oder Englisch, je nachdem, auch je nach Redner oder Rednerin. Von daher gesehen, ja, Ihre Fragen bitte. Bitte schön.